Hi, this is Dr. Rhonda Fellheim. We're going to be talking about the heart today, and this is one of the structures that we have within the cardiovascular system. And when we look at it in the context of the cardiovascular system and the job that it does for our body, it's absolutely amazing, over the top. So let yourself be in awe. Now, let me help you get there. Let me help you get in awe of this cardiovascular system and the functioning of the heart. Ask yourself, take a guess, just gander guess, how many liters of blood do you think this heart will pump out each year? And of course, I'm not hearing any responses, so I'm going to go ahead and tell you. That would be 2.6 million liters per year of blood is pumped out to the body. 2.6 million. That's amazing. Think about how big a 2-liter bottle is. All right? And then to have 1.3 million of those full of blood, and that's how much blood the heart's pumping. It's a workaholic. Well, if that doesn't make your jaw drop, then let's talk about how many miles of blood vessels the heart's going to pump blood through in the course of in the course of getting blood out to all the cells of the body. 60,000 miles. 60,000 miles of blood vessels. Oh my gosh. That's incredible. All right, so with that in mind, let's take a look at how this heart works and how all of that happens. And we'll start off, of course, with you should understand already the anatomy of the heart from previous material that's been made available or from your lab. So what we're going to look at is how this all happens inside the heart in order to get it to where it needs to go. First, we'll acquaint ourselves with a little bit of terminology, and I will primarily be using these terms as we talk about what's going on in the ventricles. So let me just use the word ventricles in front of these words to help acquaint you with this. So when I say ventricular diastole, what I'm talking about is the ventricular chambers are at rest and they're filling with blood. And if I say that we're in ventricular systole, then I'm referring to the state when the ventricles are contracting. They're ejecting that blood, okay, that they contain. Those chambers are ejecting the blood. So ventricular diastole, ventricular systole. We're going to use these terms a lot. Make sure you understand them at this point. So, how many times per minute do you think the ventricles contract and empty? And another way for me to word this is, how many times per minute is there ventricular systole? All right. Well, so I would ask, how many? How clinically, how do we determine this? It's a real straightforward way that in a clinic situation, or even here in the classroom, we could assess this with each other in a very non-invasive manner. What are we going to do? Of course, we're going to take the pulse, right? We're going to take the pulse. So, because the pulse is the blood. What we feel in the arm is actually the blood moving through the arteries in response to ventricular systole at the heart. Now, the average is quite a range, 60 to 80 beats per minute, and or systole per minute. And so so we would say, if we needed to pick a number, we would say it's about 70 or 75 beats per minute, typically around 70. Okay, so one of the things that we need to understand is about where we get this whole idea about pressure. Okay, pressure measurements. When the unit of measurement is always going to be millimeters mercury, and what we're talking about when we do a pressure measurement is, first of all, it's the volume of blood in a vessel or a chamber. It's the volume of blood that's actually going to create the pressure, because what we're measuring is how hard is that blood pushing against the walls of that structure. That's our pressure. Okay, so there are some predictable pressures. If we're looking at a healthy heart at rest, we can predict what some of the pressures will be in various structures, in various areas. So let's look at the aorta first. We say, okay, now keep in mind, this is at rest. The person is not out exercising vigorously. Okay, so at rest, and we are saying in ventricular diastole. During ventricular diastole, and please do not be looking at these other numbers right now. Keep these, don't look at these numbers. I'm talking about the aorta only. During ventricular diastole, the blood that is still present in the aorta will be exerting a pressure of 80 millimeters mercury. Okay? Now, under those same conditions, in the pulmonary trunk, during ventricular diastole, in other words, the ventricles are not contracting, the blood that's present in the pulmonary trunk is just 10 millimeters of mercury. Okay, so that's when the ventricles are at rest and they're filling with blood. Those are the values you'll see in the aorta and in the pulmonary trunk. So, let's look at the left ventricle. Now, what this 120 millimeters of mercury represents in the left ventricle is the amount of pressure that left ventricle will exert, in the amount of pressure that blood is going to have to be ejected from the left ventricle into the aorta in order to push past that 80 millimeters of mercury of blood that's there. And, as we know, this left ventricle is responsible for the push that sends this blood out to the cells of my big toe. Okay? This blood has a distance to travel. And so it's going to come out of that left ventricle with a whopping 120 millimeters of mercury. So, what you should hear me saying is these numbers in the ventricles right now represent what we would expect to see during ventricular systole, during contraction. Okay? So, this, from the left ventricle, in order to overcome the 80 and push the blood out to all the cells within our system, it's going to eject the blood with 120 millimeters worth of pressure from the blood within the ventricle at that point. As we know, the blood from the right ventricle is only going to the lungs, which is not as far of a distance. Again, the pressure in the pulmonary trunk is only 10 millimeters mercury. So for the right ventricle during ventricular systole, it will generate a pressure of 25 millimeters mercury with that blood and push it past the 10 and out to the lungs. Okay, push it past the 10 and out through the lungs. So, again, this is all of this. We're referring to an individual at rest. When we talk about these values in the aorta and the pulmonary trunk, we're referring to what's happening in the ventricles. They are at rest and they are filling. Ventricular diastole. Okay, these numbers in the ventricles are what we would see with ventricular systole.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open.
You already understand the flow of the blood. We discussed that previously, but that video was intended to just sort of cement some ideas right there after we talked about systole and diastole and use those terms as you looked at the blood movement. Okay, so when we talk about a cardiac cycle, what we're talking about is the movement of the blood through the heart once. In other words, atrial diastole, atrial systole, ventricular diastole, ventricular systole. Okay, so this is pretty amazing. So those events will occur in zero point 0.8 seconds. And this is not a number I would ask you to recall, but it's just pretty amazing to kind of keep that in perspective, that this is all happening very rapidly. Okay, so let's look at some other terminology that will help us to better understand the characteristics of blood volumes that are happening and occurring in the chambers as blood moves through the heart. So if we look at end diastolic volume, EDV, if you break this apart and we put it in a question form, what is the volume at the end of diastole? All right, again, we're talking about the ventricles. So what is the volume at the end of ventricular diastole? Well, the average is about 130 milliliters. So we could apply that here too. What is the volume at the end of ventricular systole? Okay, ESV, end systolic volume. Well, that's about 60 milliliters. And you're probably a bit surprised right now because, if as we haven't mentioned the fact that there's going to be blood left over in these ventricles after there is ventricular systole. We never mentioned there might be blood left over. Well, there is. There's blood left over, and we call that end systolic volume. Now, even if I did not have this stroke volume down here, you could figure out, just from these two values, the end diastolic volume and the end systolic volume, you could figure out and you could tell me how much blood was actually ejected from that left ventricle, or the right ventricle, but I'm just going to say one of them, okay, left ventricle, during that ventricular systole. How much blood? Well, how would you figure that out? Well, how much did we start with? 130 mils. How much is left? 60 mils. Subtract one from the other and we get about 70 mils. Okay, 70 milliliters. Well, we would say that the amount of blood that's ejected from the ventricles in one systole is referred to as stroke volume. Stroke volume. In other words, one ejection from the ventricles is referred to as a stroke volume, and it's going to be about 70 milliliters. So again, you can set up an equation to figure that out, just like we just did, and we would say that that's end diastolic volume minus end systolic volume. And it's going to be somewhere in the vicinity of 60 to 70 milliliters. Now, again, this is at rest. We're looking at an individual that's at rest at this point. This is just to help you to understand values and the average values that we would expect in a healthy individual. So we look at the heart and we say, okay, let's assess the efficiency of the heart. How efficient is the heart working? And then in this situation we'd be assessing the myocardium. How well is it being able to contract and eject blood? Well, so what we look at is what we call the ejection fraction, EF, ejection fraction. And of course we have another equation, but if you think about it, before you even look at this equation, if you think about efficiency, you already know the terms for and the volumes that we could look at in order to see how efficient the heart is working. We could say, oh, well, if I know that the ventricles have this much blood in them at the end of diastole, and then they eject a certain amount of blood, if I ask myself, well, what percent of that available blood was ejected? Okay, what percent of that was ejected? That will give me my ejection fraction. Okay, and so what we would do would we just divide stroke volume by end diastolic volume. And we would expect to see some numbers like this. An average at rest would be about 60%. Well, if you think about the numbers that go along with this, you would come up with 60%. If we said the average stroke volume is what? 60 to 70 mils, and the end diastolic volume is somewhere in the vicinity of 130 mils, that's about 60%, right? Okay, but something pretty amazing, if we look at well-trained, world-class athletes that as they're exercising, when they're really putting it out there, and they're, again, really well-trained individuals. I'm talking about people like Lance Armstrong, only without the steroids, or any other enhancement drugs. As they're exercising vigorously, their stroke volume may be as high as 90%, which is pretty amazing. Pretty amazing. That's a fine-tuned machinery that's going to be kicking that kind of an ejection fraction out there. Okay, so let's take a look at a concept that we refer to as cardiac output. Now, cardiac output, what we're going to do is put into use the value that we already recognize as being stroke volume. Okay, how much blood is being ejected from the ventricle in one systole, stroke volume. Okay, and we're going to say, well, how much blood is being pumped out per minute? How much blood is being pumped out per minute? That equals cardiac output. Well, okay, so how do we figure that? Well, we know how many, on the average, how many ventricular systoles we would expect to see per minute. That's our heart rate, right? And we're just going to multiply that by the amount of blood that's ejected with each systole, with each ventricular systole. So cardiac output equals stroke volume times heart rate, and that's going to give us milliliters per minute. Cardiac output is always milliliters per minute, volume times rate. So at 70 mils per minute, at about 75 beats per minute, that's going to give us 5¼ liters per minute. I already did the conversion for you from milliliters to liters. 5¼ liters per minute. This is at rest. Our blood will eject. Okay, so that's our cardiac output at rest per minute on the average. Of course, it's going to be variable. But let me ask you this. How much blood do we actually have in our system? This is a closed system. How much blood do we have in there that we're pumping through our heart and back out to the cells every minute? Yes, on the average we have about 5¼ liters. Okay, you should be stopping and thinking and maybe even crunching your eyebrows together because you're going, what? What is she saying? What I think she's saying? Yeah, the entire blood supply is going to pass through the heart every minute. This is another one of those moments where you sit back and you're like, what? What is she talking about? How could that be? Okay, our blood supply is going to pass through our heart every minute because of our cardiac output being 5¼ liters per minute. I told you at the beginning this was going to be amazing, and I'm following through on keeping to my word. All right, so when we look at cardiac output, and we know the variables are stroke volume times heart rate, this is at rest. What I've been talking about here, this is at rest. Okay, but we know that this can change, right? We know that cardiac output can change because when we start to exercise, we know that the cells in all of our body, especially those that are working really, really hard, are going to need more of the substances that the blood has to deliver. So these variables will change. Stroke volume and heart rate will both change. Well, we know heart rate changes. We all experience that, and that's real obvious. But stroke volume can also change a bit as well. Okay, and so let's look at what influences our heart rate to change. Now again, I want to remind you that this cardiac output that we laid out is at rest. We're going to look at, under other circumstances, what will influence our heart rate to increase, which would then indeed increase our cardiac output. When we look at variables that influence our heart rate, either speed it up or slow it down, we refer to them as chronotropic agents. Chronotropic agents. And if it's an agent that increases heart rate, speeds it up, it's going to be a positive chronotropic agent. If it's something that is going to slow the heart rate, then it's a negative chronotropic agent. Now, what you'll see here are just some categories of chronotropic agents. Of course, we would be much more specific about variables that influence the heart rate, but within the autonomic nervous system, I'm sure that from what you've learned in previous anatomy and physiology classes, you can tell me what division of the autonomic nervous system would be the positive chronotropic agent. And you're all like blurting out at me right now. Sympathetic division. Yes, the sympathetic, right? Remember how that increased heart rate? All right. Well, if I said negative chronotropic agent, which division of the autonomic nervous system would we be talking about? Well, we've narrowed it right down to the parasympathetic division, right? Okay. So we can take a look at specific hormones that have positive and negative chronotropic effects, electrolytes, blood gases. And in your text, you'll be able to take a look, or just look at this table. You can refer to your text as well, but in this table, this is from your text, you can see that some very specific positive chronotropic agents are here, negative are here. And I wanted to point out that this is potassium. It's kind of interesting that if you have too much potassium, it will slow heart rate. If you have too little, it will slow heart rate. And you know, this really does reinforce the concept that we carry through all the topics that we talk about with anatomy and physiology, and that is homeostasis. There is a very well-defined, very well-defined, acceptable levels of potassium that we can have in our system. Otherwise, it can be quite detrimental. It can kill us, and I say that falls into the category of detrimental. Okay, so again, look very specifically, of course, sympathetic stimulation. We talked about this. Epinephrine and norepinephrine. We know that in the hormone form, these are part of the sympathetic stimulation, the sympathetic system. You can see thyroid, calcium, and carbon dioxide here. And okay, so just take a look at the table, get an understanding, be able to give a couple of examples of each of those. Now, the next variable that will influence heart rate, we know, is neural control. Neural control. So we just looked at chronotropic agents. Let's look at neural control. All right. Now, when we talk about the cardiovascular center, we're talking about a cluster of neuron cell bodies that exist in the medulla oblongata. Okay, that exist in the, here they are. That's my favorite word. That's why I want to keep saying it, medulla oblongata. Okay, say it with me. No, just kidding. Okay, so here we have this cluster of neuron cell bodies, and their job is going to be to influence the heart in a variety of ways, and to influence what we will learn in the future to influence blood vessels. So, but right now we're going to look at the heart and its influence on the heart. Well, we have, look at this, two different obvious sets of nerves that are going to go to the heart, and one will carry sympathetic innervation to the heart and one will carry parasympathetic. Well, from what you know about the autonomic nervous system, you would probably tell me that it's the vagus nerve that's going to decrease the heart rate, right? It's the vagus nerve that's going to decrease the heart rate. So that would be again, parasympathetic, we said, decreasing heart rate, negative chronotropic agent, or variable. Okay, so the nerves that then will carry the sympathetic innervation to the heart, which is going to increase both rate and contractility, but we'll focus on rate right now. These are called cardiac accelerator nerves. And of course, if it's increasing the heart rate, then we've got to know that it's sympathetic. So the way that I remember this, cardiac accelerator nerves, is that when you want to accelerate in your car, you put the pedal to the metal and your car accelerates, it speeds up, right? Okay, so cardiac accelerator nerves we need to put the pedal to the metal in order to make that heart rate increase. All right? So then innervation of the heart, although it's going to be coming through the nerves associated with parasympathetic and sympathetic, the cardiovascular center messages are going to be influenced, as you can see, by a number of other areas. Well, we know that we have control over and some influence over our heart rate, right? So from the cortex, the higher brain centers, we can influence heart rate. I mean, think about it. If you, let's see, say you're walking through Publix and you turn into the pickle aisle because you're going to get some of those sweet chips, pickles. All right, so you turn in the pickle aisle, you're walking up, you're just about at your pickles, and lo and behold, you look up. Who is standing there in the aisle but somebody that you have this huge crush on? And it's like, oh my gosh, and all of a sudden your heart starts racing, right? And your hands start sweating. Okay, so we know from 28.5 that's a sympathetic response. Well, all right, so think about future visits to Publix now. Well, okay, so you turn and you go into that pickle aisle. You start thinking, thinking about what happened the last time in the pickle aisle, and oh my gosh, am I going to see that person again that I have such a crush on? Doesn't your heart rate increase just from the thoughts you're having? Yes, it does. I mean, purchasing pickles can take on a whole new meaning for you. Okay, but I'm not going to go off on that tangent right now. I just want you to remember now that, excuse me, we do have some influence into that cardiovascular center and the messages that are being sent out then. Another source of input to the cardiovascular center comes from different receptors that we have located throughout our body, and this is a good time to introduce these because we'll be looking at these from a variety of views through different systems that we study. So when we talk about proprioceptors, you should have learned this in 2085. If you didn't, proprioceptors are receptors that we have in our joints, and as we move our joints, and just for example, I think I can help you understand it by just giving you an example. If I walk up to the edge of the pool and I bend over and my arms go back as if I'm going to dive in the pool and start swimming laps, just that joint movement gives my cardiovascular center input that I'm about to exercise. And do you know that the cardiac accelerator nerves will carry impulse to the heart and increase my heart rate before I actually even start exercising? Of course, it's not going to race out of control, but it will start increasing just in anticipation of what's about to come because of the input from the proprioceptors. Input from baroreceptors. When we talk about baroreceptors, we're talking about pressure receptors. Now, those pressure receptors are monitoring blood pressure, and where we're very, very interested in monitoring pressure is in the arch of the aorta, because that's going to monitor the pressure of the blood that's heading out towards all the cells all over our body, all over our body. And then there are also baroreceptors in the carotid arteries. Okay, in the carotid arteries, because we want to monitor the pressure behind the blood that's going to the brain, of course. That's priority one. What's going on with the brain, for the brain? All right, well, that information is going to influence heart rate. Chemoreceptors, again, we have chemoreceptors in various various places, again, in the carotids, in the aorta, and also around the medulla. And we'll be looking at hydrogen, CO2, and oxygen levels, which indeed will influence the rate of the heart. So input from these areas influencing the rate of our heart. So again, just to remind you, we're talking about cardiac output and variables that influence the heart rate aspect of that, which will in turn influence overall cardiac output. So let's look at stroke volume and how it may possibly be influenced by other variables. And again, stroke volume is the amount that's ejected in one ventricular systole. All right, and cardiac output again is output per minute. Okay, so let's look at stroke volume. Three variables, and again, these variables are influenced by various circumstances, various other conditions within the body. So preload, contractility, and afterload. These are the three categories of variables that we're going to look at next that influence stroke volume. When we talk about preload, essentially what we're talking about, and you can see here in parentheses, venous return. Essentially what we're talking about is the amount of blood that's returning to the heart at any given time. Well, at rest, we would expect a certain amount of blood to be coming back to the heart per minute. But if you're exercising, that will increase, and the rate at which it returns will increase. And so it will place a certain amount of stretch on the myocardium as it returns to the chambers. So this guy, Starling, he discovered, he looked at, he did the research, and he said, well, you know, if we look at these cells in the heart, these muscle cells, the more they're stretched, the harder they contract. So we call that the Frank-Starling law of the heart. The more you stretch a muscle cell of the heart, the harder it will contract, meaning the more forcefully it will contract. All right, so let's apply that to preload. Okay, the more blood that returns to the heart. Let's say I'm at rest and I get up and all of a sudden I take off running up the steps. Okay, I take off up the steps. Well, all right, so all of a sudden my body's going to go, whoosh, let's get more blood back to the heart, because she's going to need to get blood out to all those cells in her legs that are working really hard running up these steps. All right, so there's going to be a little bit of a surge of blood that returns to the heart. Well, it's going to stretch those muscle cells in the heart, the myocardium, and as a result, they will contract more forcefully. And when they contract more forcefully, don't you think that's going to do what to your stroke volume? Yeah, it's going to increase it a bit. A little bit more blood's going to come out. All right. So let's look at inotropic agents. Inotropic agents, positive and negative, will influence the contractility of the heart. All right. Well, Of course, contractility, as we just explained, contractility has to do with how forceful are the ventricles contracting, how much force are those myocardial cells contracting with. Okay, how forceful, how strong of a contraction is there. So that we refer to that as contractility. So if it's a positive inotropic agent, it will increase contractility. It will make the contraction more forceful. If it's a negative inotropic agent, it's going to make the myocardial cells contract with less force. Okay, so here we have another table from the textbook looking at positive and negative, and they're going to again influence the contraction strength of the myocardial cells. And we would expect there to be a positive effect from the sympathetic, right? From excessive calcium, all right? And if you think about it, calcium plays a very significant role in the action potential of a myocardial cell. And so you want to put that together here with this information. Again, here are some other specifics. Very specific with negative inotropic agents. So take a look at this and just get an idea, several examples, and the general types of variables that influence the stroke volume either positively or negatively. Okay, so following are some questions that you should be able to ask yourself and kind of work through at this point. And I'm just going to flip through them slowly so that you can then stop the video, you can work through the questions and do some thinking about this. Work with the numbers. Do it now so while this information's fresh. All right, so again, when we talked about stroke volume, we said preload, contractility, and afterload. So I want to explain afterload to you before we move on to more questions. Afterload, we've already defined it pretty much, and but not really in this context. We already talked about the pressures that will exist in the aorta and the pulmonary trunk when the ventricles are in diastole, when they're at rest and they're filling. Remember, okay, let's go back to these pressures that exist. Well, if you think about it, those pressures, as we said, they're going to create a resistance that the ventricles have to overcome when they contract. All right? Well, that resistance, okay, that resistance that the ventricles have to overcome in the aorta and the pulmonary trunk is called afterload. Those are the forces or the pressures. You could also use the word pressures that ventricles must overcome. Now, I've had students say to me at this point, well, what's the relevance of this to the real world? And I think that's a great question because it really does help us to cement this idea of afterload and what it really means. We got these numbers, again, I want to remind you that these numbers are the numbers we would expect to find in an individual that has a healthy heart and that they're at rest, all right? Well, let's talk about someone who doesn't have such healthy arteries. I mean, we've all heard about plaquing in the arteries from consuming, too many bad fats. Well, and I say bad fats because I have to put this plug in that there are a number of good fats that we should be consuming. So anyway, too many bad fats can create a situation where there is plaquing in the arteries. Well, what do you think is going to happen if you create plaque along the walls of the arteries? I'll tell you, you're going to decrease the lumen size. Now, the lumen is just the opening in the vessel. It's just the opening where you find the blood inside the vessel. Well, if you take that opening and you make it smaller, I'm sure that you're finishing this sentence by now. If you make the lumen smaller because of plaquing in the arteries, you will increase the pressure, because remember, you'll be increasing the volume of the blood. Didn't change. The pressure, how hard it's pushing against the walls of the artery, will increase. That will change. So let's just say, as a result of plaquing in the artery, this number, instead of 80, is now 90. 90. So we say, okay, well, we've got a 90 here. That's our afterload. That's our afterload. That's an unhealthy afterload, but that's an afterload. Afterload has increased. It has increased to 90 because of this condition. Well, what does that mean for the ventricle? Well, that means that for the ventricle, if 120 is the amount of pressure needed to overcome 80, well, if you increase that to 90, then the left ventricle is going to have to push harder. So it may go up to like 135 in order to push past the afterload of 90. Whoa. So are you telling me then that the heart is going to have to work harder if I have plaquing in the arteries? Yeah. And what that means then is that that's additional wear and tear on your heart that's unexpected, and it can shorten the life of the heart. You're overworking it. All right. So again, what we're dealing with here is the pressure that the ventricles are up against, that they have to overcome. And plaquing in the arteries is not the only condition that can increase this resistance, and this is where I would use the word resistance, because the blood in the aorta and the pulmonary trunk, this creates a resistance to the ventricle pushing its blood out. So, bottom line, let me ask, do we ever want to increase our preload, or do we want to keep it as low as possible? We want to keep it as low as possible. Right. We want to keep our afterload, we want to keep our afterload low. We want to keep our preload at a healthy high, where it normally would be. So we look at the long-term effects of exercise, and this is just sort of a summary, because really the variables that we've been discussing, they all play a role here. But resting cardiac output. So at rest, we would expect the cardiac output to remain very close to the same as of other individuals. However, when we look at a well-trained athlete or somebody that's in really good shape, we see that their heart rate is typically what? Much slower, right? It's on the lower end of the average range. So if it's lower, in order to generate a comparable cardiac output, wouldn't that mean that the stroke volume would have to be a little bit more increased? The heart would be more efficient. Yes. And that's why they can have a lower heart rate, is because their hearts are more efficient, well-trained, people who are in very good shape. Okay, afterload, if you exercise, it will actually decrease the blood pressure, meaning the actual resistance that the ventricles are up against, so afterload goes down. Ejection